I would like to thank AIOC. Thank you, Sonu sir,
Welcome,
KP sir,
Gairik.
for giving me this chance. I'll be speaking on artificial intelligence, more to do with refractive surgery and keratoconus. I have no financial interests. So my field of interest, I am currently pursuing a PhD in artificial intelligence, and I'll be speaking on the various aspects of work we are doing, looking at obviously the time constraints. It would be brief. So, not only as practitioners or clinicians, we have multiple tools and diagnostic tools and indices which we keep looking at or hearing. But the challenge obviously lies in trying to figure out what do we make of it, or what do we actually look at it. If you're looking at keratoconus, there are not only diagnostic tomographical parameters, you also have to look at high risk scoring or demographics, which can play a role in these cases. So what normally happens is that we are not really able to combine many of these parameters, and that's where artificial intelligence comes into play. Is the human bias in looking at parameters which we are comfortable with, or things which we are actually more aware of, is what we normally look at, and that's where AI comes into the picture. This is no imagination will replace clinicians, but can be used as an add-on tool for our current practice. So artificial intelligence looks at algorithms which normally we don't look at. The various permutations and combinations, various connections at many levels. It can be imaging, it can be correlating demographics, high risk characteristics with imaging. So there are a lot of permutation and combinations which sometimes we are not really able to figure out as clinicians, is where AI comes into the picture. What we did, and many of the work we do, is something which looks like a decision tree classifier. So there are various classifiers when you're looking at AI. The main concept of artificial intelligence is you put in data, whether it is indices, whether it is demographics, and it helps in building this tree, which looks like a tree, a branching tree. And each one of these nodes or these points are actually one of those factors or determinants, whether it's an index, whether it's a high risk score. So there are various classifiers. What we normally use is something known as a random forest classifier. There is something known as a neural network, and there's something known as SVM, which is a support vector machines. RF classifiers in majority of our work has had the the best area under curve, and that's the reason why we use RF classifiers. So what we did, first aspect of work which started 2 years back, was looking at keratoconus and how keratoconus progression can be detected and predicted earlier. And that's the work we've been doing. And we have built a database of over 450 patients, looked at each one of those time scans, and utilized that to develop an AI algorithm. What is important is two aspects. One is known as a training data set, and one is known as a testing data set. We input all of this information into the AI and teach the AI what it's supposed to look for. Now, how do we test it? We can either use a separate data set and test it, or within the training data set itself, there could be a small subset of data which can be used for validating what we have actually taught the AI. So that's an important aspect of utilizing something known as a training data set and a testing data set. Now, what we did differently in the lockdown, just prior to the lockdown, this is way back last year, is we were finding a lot of patients who were coming in. Surprisingly, they were stable prior to the lockdown, but some factors might have changed as to why many of them started progressing. Now, this can be extrapolated to all patients of keratoconus, but the AI we have built on demographics were on a subset of patients who actually progressed. And we looked at the various demographic profiling, high-risk characteristics. If you're looking at vitamin D, B12, Ig levels, hours spent outside, hours spent indoors. These are the other factors which we looked at. So this is something which we have also added to the AI algorithm. So what we found is a lot, combination of indices, which is what is important. What is also interesting is that AI was also able to use these high-risk characteristics. If you look at classification between progressors and stable, it used vitamin D as one of the parameters, which we normally don't look at. Also, we classified patients who had a progression of more than 2 diopters and classified it as aggressive progressors. And IgE, which we normally don't look at, an IgE which is more than 800, suggestive of a large number, a high systemic allergy. These patients also were picked up the artificial intelligence algorithm. So this is the paper which we recently published. The first aspect, which is the imaging, the demographics is something which is still under review. Now, epithelium can be a confounder. What happens is, I think Rishi sir has spoken very well about epithelium and the role of epithelium, is that it can actually mask many changes. Even post-refractive surgery, an epithelium healing pattern can give us clues as to how the outcome would be. And this is a slide which is basically trying to show us that there are many modes of epithelial healing. Even routine procedures, routine preoperative topographies can heal in a different way. And that's what is important for us to understand. This is the next aspect of work which we published, where we looked at a subset of patients who had undergone refractive surgery and quantified the indices from the OptiView scan, in these cases, no financial interests, and derived at something known as epithelial Zernike's indices, which were either focal changes or global changes. And what we figured was that an AI was able to pick up a suitable procedure by just looking at the epithelium. So we are obviously far away from it, from clinical translation, but feeding all of this data gave us better understanding on how epithelium could be a way to look at post-operative outcomes. So there are various applications. We looked at keratometry. We looked at patients who had ectasias using epithelium. We also looked at patients who had regression. These were all the validating data points which were fit in to the algorithm. Now, what also happens is that many of the topographers actually do not look at where we are actually supposed to be looking at, and that is actually at the stromal level. Majority of the treatments are actually treating the stroma, and epithelium can be a confounder in these cases. And therefore, studying epithelium is very important in addition to looking at topography, because the current topographers cannot really dissociate the epithelium. So where we are actually supposed to be looking at is what the arrows in red signify. We have also done a study on MS39, which is an epithelial tool using these multiple indices. And what is important is that majority of the parameters which were picked up by artificial intelligence to distinguish between a normal or an FFKC or a KC was the level of Bowman's. So it's trying to say that, the Bowman's level imaging is what is essential in these cases. So AI has obviously changed the way we look at, this is again a paper which we are, it's under review. And there are various aspects of AI, whether it is, if you're looking at topography, if you're looking at demographics, or you're looking at biomechanics, the final revolution would be trying to integrate all of this. Thank you for the chance, and thank you.